I was very tempted to try and do, Ilan and I were talking about this over lunch, I was very tempted to try and reflect on my own life and how it is that I got to the place that I am right now, but I'm going to resist that temptation. I'm not going to do it. Maybe it'll spill out in various ways. I will say that I do spend a lot of time, I'm here at Bar-Ilan in the psychology department, which when I came in, I think the only person in the department who was doing anything other than psychodynamic psychotherapy was Eva, and I think had been doing it for several years valiantly, keeping up a front against a lot of opposition in the department, and made my life very easy to come in as somebody whose original training was CBT, but is more integrative, so I got to be the good cop. Eva remains the bad cop to this day, and I'm the good cop who comes in with a softened version of an approach called schema therapy that I want to tell you a little bit about as a model of integration, and I think it'll touch on all sorts of things that people talked about. So my objective is to try and give you a little bit of a sense of what schema therapy is, and towards the end there will be a quiz to see which kind of integration from the ones that Golan talked about yesterday this is. I don't know the answer, but maybe Golan will tell us the answer. What I'm going to try and do is use schema therapy because I like it as an example of an integrative unifying theory and treatment that I think touches on almost everything that anybody talked about over the last 2 days. So just as a background, this is an approach that's been around for about 30 years, maybe a little bit more than 30 years. It's designed to treat long-standing problems. It was originally developed by an American psychologist named Jeffrey Young, who grew up at the University of Pennsylvania, but not in the Seligman tradition, but in the Beck tradition, so across the street from where Seligman was, and grew out of it. So in a way, it started off as a cognitive, in fact, it was first called schema-focused cognitive therapy. So it was seen as an offshoot of cognitive therapy. But over the years, both in the work that Jeff himself has done and the work that other people have done over these decades, it's grown to be, I think, quite different than its origin, and to incorporate ideas from psychodynamic approaches, from attachment theory, from emotion-focused model, and particularly Gestalt, and possibly from other things. And it also now is a technique that is used also with children and adolescents and couples and groups, but really the origins were to think about adults. So that's the very basic. And I'm going to give you some sense of what the approach is, but I'm going to start by going outside of the approach itself and say something about the theme that one theme that I'm hoping to hit here, which is that we're not hosts. There is no home. This was my question when we started yesterday. I don't think there's a home here. I think if anybody's the host, it's the patient. And we're visitors in the patient's home. And our role is to meet them where they are, meet them in their homes, get their needs met. The notion of needs has come up in a few of the different talks here. And we may be pretty informed visitors. We're visitors who have opinions. We're visitors who have all sorts of ideas. But we're entering their homes, and we bring with us these ideas, and I'll give the illustration of what I mean by ideas in a second. We also bring with us certain practices, which we're sort of inviting or suggesting them, even though we're the visitors, we're inviting them to try on, but we're not imposing upon them. And we do this within a certain set of, not just one, but set of relational stances. There was a different term, John, that you talked about yesterday. I forget what the term exactly was, but I think it was similar to this notion of how is it that we are. You distinguish between technique and sensibility, or there was some sort of a term you used, or I would use the term stance. How is it that, what sort of attitude or stance do we bring into the therapeutic room? And that's part of our approach in schema therapy, so I'll spend a minute talking about that. But in any case, all these things are from the perspective of being a visitor, not being a host. There's very few ideas in schema therapy that's part of, I think, its explicit purpose is to be a very clear and communicative kind of approach that speaks to therapists from different orientations and also speaks to their clients. using as few terms as possible. So he tries to be really parsimonious and yet flexible. So by the end of the next 15 minutes, you'll know all the terms you need to know about schema therapy. We could spend years talking about them, but at a very basic level, there are 4 terms, the first one of which is schemas, which gave the therapy its name. Surprisingly not the most important concept, I think, but historically it was. Really, when Jung talked about schemas, he was borrowing an idea that existed before. In cognitive psychology, starting in the 1930s, the work of Bartlett. In cognitive therapy, Beck was already talking about schemas in the 1960s. But what Jung did is take the concept and expand it to quite a major degree, so that he thinks of schemas as maybe similar to object representations, but in a very rich way. So they're more than just cognitive. They're cognitive, they're emotional, they're semantic, they're episodic, they're an amalgam of all sorts of things that are more than just the core belief, more than just the cognition component of it. And they have to do with one's own life and one's relationship and maybe the world. So there's the Beck cognitive triad that can be seen for those who like that kind of stuff. But the more important thing is that the schemas that are interesting for us are the schemas that cause problem. They're the ones that are problematic. There are plenty of schemas in the world. The ones that this therapy focused on, given that it's a negative psychology, not a positive psychology kind of approach, are the schemas that have to do with sort of maybe distorted ways or biased ways of seeing oneself and one's relationships that cause problems to oneself and to one's relationships. And the argument is that there are things that develop early on. So here you're starting to see where this goes beyond, I think, classic cognitive therapy, which is not that interested in etiology. It's much more interested in the maintenance factors. And here there's a major focus on, wait, where does this come from? This comes from childhood, it comes from early experiences. Let's try and explore these experiences because it's necessary in certain respects. Not in every respect and not at all times, but in certain respects, and particularly for the people for whom this therapy emerged, which are people with long-standing problems, maybe people with personality disorders originally, but I think now we would think of it as an approach that's pretty relevant universally. For those people, or for everybody, the argument is that it's not enough to just think about maintaining factors. Sometimes the maintaining factor is in fact the history. Is in fact the traumatic memories, or is in fact the early learning. And so we got to be interested in that. And the argument is that these schemas evolved when the early learning was of needs not being met, of major needs, which by the way will be the second idea, and I'll talk about it in a second, but needs not being met through some combination of environment being really depriving or off, one's temperament being hard to soothe or please or meet the needs of, or culture and environment, not just in the episodic sense, but in more immersed sense, affecting the way these needs are or are not met. The idea is that these are learned early in life, but then elaborated on throughout life. So once we've started establishing a certain way of seeing the world, things will fit. We'll keep seeing all sorts of confirmation for that, and we will miss out on disconfirming information. This is the point that Ilan was making yesterday about how it's not just enough to meet people. You've got to meet people and have some sort of a disconfirming new experience. So these are schemas, and they give us the first concept in schema therapy. The second, which I already noted, but I think is actually more important to schemas, are the core needs that underlie the schemas, which I think are exactly the thing, Jonathan, that you and your student are studying now. Right? Basically, you're doing the process of trying to say, underneath these fears that we have, or underneath these behaviors that we have, what is the core underlying motivation? And Jung did this process. He did it from the armchair. So he sat in the armchair, read a lot of literature, and concluded that there are 5 domains of need in life that are central. And if you look at them, you'll see a lot of similarity between them and other approaches for needs and for actually for development. You can see the imprint of Erickson here. You can see the imprint of Maslow. You can see all sorts of imprints here. And in fact, I don't particularly like this part of schema therapy, and I'll show you a version of it that I like better in a second. But the basic idea of let's try to see what are some universal core needs and what happens when they go awry, when meeting them goes awry, that part I like a lot, and I think that part is essential to thinking in a schema therapy sort of way. In fact, the way that I would suggest, if you're going to be adopting this approach, that you'd work is based on a newer model. Recently came out as a psych review paper by Carol Dweck, who's not a schema therapist. I don't think she's even clinically trained. She's a developmental, social, emotional, motivational researcher at Stanford, whose paper from 5 years ago by now is the best paper I've ever read, ever, in psychology. And I think it presents all sorts of really, really interesting things that look a lot like schema therapy in the process that she goes from looking at how needs are A, universal, B, she presents a certain structure of needs that I'll show you in a second, how these needs lead to goals at the individual level, not just in therapy, and how when those goals are met or unmet, we develop representations, which are, she doesn't call schemas, but basically she's talking about schemas. And so when she says that she's setting a foundation for a unified theory of motivational personality and development, which sounds ambitious, I think she actually kind of delivers on it. That's why I like this paper. In any case, the theoretical model of needs that she presents talks about innate needs, needs that appear really from the moment of birth, and she talks about just 3 of those. The need for acceptance, the very basic attachment need to be cared for and belong to somebody. The need for competence, which she sees she's done infant research herself, and she shows how even day-old infants show all sorts of biases towards things that suggest a sense of competence, even though they're completely incompetent, as we know, and remain so for about 18 years. But she also talks about this need that I think isn't highlighted by Jung and isn't highlighted enough by others as well, which is the need for predictability, the need for having some sense of a world that is where I understand the cause and effect, where I understand where things are leading from. And that's something that's, I think, missing from many major theories, and I love that she talks about it, and she argues that it's an innate one. And then on top of these 3 basic needs, she sees 3 compound needs that are made up of combinations of basic needs and emerge somewhat later in development, not much later, but within the first year or 2, but they're not innate, and they require both these underlying needs, but also a certain cognitive infrastructure. You got to have object permanence to be able to have the need for trust be relevant. Before you got object permanence, it doesn't matter. The need for esteem requires for you to be able to recognize others and then feel whether you're as worthy as they are or not. The need for what she calls control, which is really autonomy, is something that requires, being able to see that there's authorship of action, that some actions are done by me and some actions are done to me or I'm forced into doing. So that's a second layer of needs that emerge with development. And then the third thing that she talks about is the need, she calls it self-coherence. It's the need for meaning and the need for identity. It's a combination of very lofty needs that emerge even further on in development. I like this a lot better than I like Jung's thing, partly because it's research-based, partly because, unlike Jung, who sat very deeply into his armchair and thought about needs, she's been in the lab for 50 years doing infant research and summarizing other people's research really well. So I like her needs model. Happily, other people in schema therapy like her needs model as well, and it's starting to make its way into the writing of other people within this approach, which I think gives me a hint back to Golan's question of what kind of a model do we have here. I think we have a self-correcting model. We have a model that's trying to learn. So in any case, those are the first 2 ideas in schema therapy, the idea that there are needs and that schemas emerge from them. And going back to the way that Jung had it, he again, from his armchair, sat and thought about any kind of possible schema that he could think of, and for a while that list included 15 items, and then he dropped a few and he added a few, and now their list includes 18 items, and I couldn't care less about what the right number is. Maybe there's 18, maybe there's more. The idea of these schemas being connected to needs is the central point of schema therapy. Do they actually fit into this kind of five-factor structure that is laid out here? Apparently not. Actually, there's recent work from Jung himself showing that, nah, it's not 5 factors. Doesn't matter so much. What matters is seeing how needs go unmet and representations schemas develop. So those are 2 basic ideas. The third idea that schema therapy, or that Jung actually even early on in the development of this approach talked about, is the idea of coping styles, in the way people try to cope with their schema activation, basically. And he borrowed ideas, in general he loves borrowing things, and he borrowed the ideas of sort of the ethological way that organisms deal with stress, which is fight, flight, or freeze. One could argue that there's a fourth kind of strategy as well, which is fawning or surrendering, which is a little bit different than freeze. But fight, flight, and freeze as things that we would do if we're encountering a bear in the woods are also, if we borrow these terms, the kinds of things we could do when we encounter the internal bear in our internal woods, which is the activation of our schemas and the distress that they bring with us. So we could give in to the schema and surrender to it and become compliant or dependent or anything else that goes along with what the schema tells me about myself. Basically identifying with the aggressor, the internal aggressor. I could run away from it in a variety of avoidant ways, and I think the social anxiety example that keeps being discussed here is maybe the best example, but it's true in so many other ways in which we could be escaping distress. And the third way is we could try and do reaction formation, or we could try to counteract and act in opposite action to what the schema tells us. If we feel very alone, we could act as if we don't need anybody, or if we feel very out of control, we could try to be hyper-controlling and so on. Those are nice ideas, and the argument that Jung made was that schemas are a problem, but these are the real problems. That the problems are often not that there's a schema, it's that what do I do when the schema gets activated, and that our job is to try and find a unique combination of schema and coping style and try to work with that. And that lasted for a few years. Oh, I never showed you this. I was looking at my own screen. Yes, you can ask me a clarification question. No, absolutely. So just like there are these early maladaptive schemas, we could have positive adaptive schemas. We just don't bother talking about them because why waste our time? No, I mean, there's now people interested in the integration of schema therapy with positive psychology, and in trying to think about what healthy parenting or healthy schemas or healthy needs being met would look like. But that came much later. So the first attempt was to try and think about where things go awry. All right, so when I was talking about the categorization, this was the categorization that I was referring to. And even when I spend a lot of time, not just 30 minutes trying to rush through what schema therapy is, even if I spend a semester-long course, I don't bother looking at what the schemas are. I don't care about that. And I don't want people to learn what the difference is between a failure schema and a defectiveness schema. That's not the point. The point is the idea of a schema, the idea of having a representation of the world as one in which I'm constantly a failure or constantly deficient and so on. So coping styles, as I said, are the ways in which we adapt, and there are these general 3 tendencies, maybe 4 if you use fight, flight, freeze, and fawn, which I kind of like. But the point is, this was schema therapy for a while. It was an approach that Jeff developed first as really somebody very close to Aaron Beck at the University of Pennsylvania. He was the director of training and research in the Beck Center in the, I want to say, early 80s. And then gradually started gaining some independence. He would take the train up to New York. He set up a clinic that was called the Cognitive Therapy Center of New York. So it was seen really as a satellite of Beck's approach. But he started meeting these New York patients who were harder. They weren't these compliant Philadelphia patients who came in and got better. They were harder, and also the milieu around him. New York then was entirely psychodynamic, psychoanalytic. Today, I'd say it's only 80% psychodynamic and psychoanalytic. So there was the milieu around him, and that made him stop and reconsider all sorts of things. And one of them was the realization that these ideas, the three ideas that I've mentioned so far, are just not enough. They don't work well enough. It's not that they're wrong. They capture something. There are these needs. There are these representations that happen when needs go unmet, and people do cope with them in stylistic ways. But for the very patients that he was hoping to make a dent with, they weren't making enough of a dent. And the reasons had to do with the fact that these patients, and I want to argue that everybody, doesn't fit very neatly into having one or two or three schemas. We often have many schemas, and particularly patients with personality disorders have lots and lots of schemas in all these domains and have unmet needs in a variety of ways. So that's one thing that doesn't work. But the second thing, and it's more fundamental, is that all three of those concepts that I mentioned so far, the idea of needs, the idea of schemas, and the idea of coping styles are traits. They're things that are characteristic of a person consistently over time, and yet people in general, maybe people with personality disorders even more so than people in general, fluctuate all the time, and they change, and they have different ways in which they behave, even in the same therapy session, right? And so if we want to be able to describe that phenomenon and work with it, we need a language for talking about it, and that three terms or three ideas that I showed so far don't do that, which is where a fourth term began to become necessary. And so when you read schema therapy books, you see the first book only came out in 1990, so 32 years ago, and it does not mention this concept. It only talks about needs and schemas, and it has a very long and completely useless questionnaire called the Young Schema Questionnaire that helps you, find out what the schemas are, and then work supposedly based on one or two or three of these schemas. 13 years later, when the next major book by Young comes out, it already has this concept, and the therapy changes, is transformed in a major way. And it takes in this idea that I think has been mentioned here by a few different people. I think Monica talked about it today beautifully. I think you call these complexes. I think Ilan talked about it as the different personifications of, let's say, emotions that people have. I think Rumi talked about it in the poem that you had up there, the first states. The idea that people fluctuate from moment to moment. They have different states, and these states, which I think many theoretical approaches recognize, are related to their moods or their emotions. They're related, but they're more than just emotions, right? They're emotions, they're motivations, they're cognitions. They're often physiological states that people are in, and we got to be able to track those and find what those are. And I think that concept is a lot more central to the way schema therapy is practiced than schemas, which means that the term schema therapy is sort of a misnomer. I like at this point to show that I read books too, and bring you a little quote from a wonderful novel that came out a couple years ago called The Nix by Nathan Hill. Highly recommend it. This is a story of a woman named Faye. And somewhere towards the end of the book, Nathan Hill writes this. He says, in the story of the blind man and the elephant, which we all know, hopefully, what's usually ignored is the fact that each man's description was correct. What Faye won't understand and may never understand is that there is not one true self hidden by many false ones. Rather, there is one true self hidden by many other true ones. Yes, she is the meek and shy and industrious student. Yes, she is the panicky and frightened child. Yes, she is the bold and impulsive seductress. Yes, she is the wife, the mother, and many other things as well. Her belief that only one of these is true obscures the larger truth, which was ultimately the problem with the blind men and the elephant. It wasn't that they were blind, it's that they stopped too quickly, and so never knew there was a larger truth to grasp. What schema therapy tries to do is to not stop too quickly. So it tends to be an approach that takes a little bit of time, although at the same time, to kind of be focused in doing this kind of work. And one thing that helps us do that is that we have a certain template in mind of what we think are possibly the complexes or the modes, we call them modes, that people have, and we tend to categorize them into these 4 categories within which there's several examples, and within each example, let's take just the first category of child modes, and the first sub-example of the vulnerable child mode. Within that, there could be lots and lots and lots of variations, certainly across people, but even within the same person. My vulnerable child mode might look different from moment to moment, but at the same time, there might be something useful in recognizing that we all have something like that, a part of us that carries the pain, the stress, and maybe feels most of the schemas, maybe not all, but most of the schemas that we may have in the most raw way, thank you. And that we all also have at least the capacity for anger, a part of us that is a mode that reacts to the needs not being met in some sort of an almost instinctual way, that we all have some capacity for impulsivity, although some of us with ADHD genes have more of that, that we all have some capacity for feeling contented and happy and having our needs met. Unfortunately, not everybody has their needs met, but we have the capacity for it. And similarly, we could go through each of the examples here, but I'll just go over the categories for the sake of time. Tell me how much time we have. Fantastic. So the 4 categories try to give us some sense of what modes we might expect to see there. Now, they're going to be different from each person, and we're going to want to try and identify them collaboratively with the patient or client. But generally speaking, we expect there to be these child modes which tend to carry within them the more basic emotions. We expect to find coping modes which are a little bit like those coping styles I mentioned earlier, except without the demand for it to be a style. I don't have to be somebody who's always avoidant. I can have moments of avoidance, and that's important enough. So I can have these moments of detachment or avoidance or overcompensation or compliance. And when I'm in that moment, I'm in that mode. We tend to have these introjected, I should have changed the word here from internalized to introjected modes of voices, which is that thing that we were talking about earlier, of having parts within ourselves that really don't like us or that are at least kind of nasty to us. They could be punitive, they could be demanding, they could also be a bit more benign but still harmful, permissive kind of representation or introjection. And finally, we have the capacity at least, and sometimes we actually have a healthy adult mode, which is the part of ourselves that I think is reflective and is capable of integrating among these other parts. So schema therapy suggests that there are these modes, and it suggests that to work, so far it's just theory, right? But it suggests that the work itself is going to involve trying to get the right formulation, so trying to talk with the patient and understand what it is that they need and they're not getting met, or in the past have not gotten met, what it would take for them to get those needs met, and how that would require ultimately changing the schemas, but even before that, trying to identify the modes and the coping styles and trying to do some work with them. So that's the technique in a nutshell, which really brings me to the second theme that I wanted to talk about, which is the theme of transparency and explicitness, which I think, again, was mentioned in a few of the talks earlier. If we're visitors and we're coming into the patient's home, and we have these ideas, which I think are really, I just spent 15 minutes talking about them, and you got them, right? Because they're very understandable and universal. That's great, but we want to be able to bring those ideas to the clients and have them buy into them, and if not, we don't have a contract to do the work. So we want to bring these ideas. In a minute, I'll talk about some practices we might want to use. Whatever we do, we want to do it with humility. So, I really have this strong belief that people have needs, and that there are these schemas and there are these modes, but I don't know Ilan well enough to know what his needs and what his schemas and what his modes are. And so with a lot of humility, I want to spend some time learning about you, and be really explicit about what it is that I think, but be open to revising it, because maybe you think differently and you're right and I'm wrong. And then be transparent about the practices that we want to use in the work, and this is particularly true, it's true with specific techniques. So we like using things like imagery work, and we like using things like behavioral therapy techniques, and we like, but I think the place where it matters the most is in how we stand, what therapeutic stance we bring into the room. So I want to spend a minute or two talking about each one of these things. First is this idea of conceptualizing and setting goals, which I think is very central to many approaches, but is very explicit here. So I think every therapist has some formulation or conceptualization as they're working. What we try to do is make that formulation and conceptualization, never know the difference between those two things, make them as understandable to the patient herself. And as you see, the terms aren't hard to understand. Needs are not a term that people need, a dictionary to understand. They get it. Parts is something that people get very intuitively, I think. So we propose a conceptualization using the terms, and we share it, we collaborate on improving it, and then we try to derive some consensual goals from it. And that may be something we do more than once, but we try to do it early on in the therapy to get going, and then revisit it when we need to, and then work with whatever means make sense to us. So we're pretty eclectic in terms of the techniques we use, but there's a strategy, there's a thinking about what we want to do. And beyond the specific techniques, there are these stances that I mentioned. The stances really correspond to what we would want to do when we meet a patient in a particular mode. So if we see somebody and we get that they're vulnerable, we get that they're in a moment of pain and distress, and that distress doesn't seem manipulative, and it doesn't seem, what else could be reasons that it might be not real. It doesn't seem feigned, it doesn't seem like it's made up. It's a real thing. It's, they're sobbing and they're in pain. What we encourage trainees in schema therapy, and what we try to do ourselves, is to do what I think, compassionately anyone would want to do in that moment, which is, respond the way a parent would. And we call that approach limited reparenting. It's the idea of seeing moments in which we see the patient fundamentally experience the world as a child in the moment, as moments that require meeting some needs very directly. Schema therapists tend to, I think, use themselves as a source of meeting a patient's needs, more so certainly than anybody else in the CBT world, but I think more so across the board, even compared to, say, self-psychologists. So we think that the therapy relationship is a locus of meeting some needs, not all the time and not for every mode, but when we see child modes, when we see somebody who's vulnerable, and we think that vulnerability requires some consolation or some help, or we see somebody who's angry, and we think that they require validation, but also maybe limit setting so that they don't harm themselves, or when we see somebody who's impulsive and we think that they need us to be cautious for them, to be protecting them from damage they might be doing impulsively to themselves. Or when we see somebody who's contented and we think that it's a great thing, we want to join them in that contentedness and, metaphorically or not, get down on the carpet and play with them. Those are all variations of what we would call limited reparenting. But that's not the way we want to be in other moments. There are moments when we see the patient maybe behaving in ways that are understandable, but that are maladaptive. That's what we call the maladaptive coping modes, these ways in which they might be fighting, fleeing, or freezing, or fawning, or surrendering, or protecting themselves in ways that are, again, understandable, but we think are ultimately not in their best interest. And then we don't want to be in a parental mode quite as directly. We want to, we encourage therapists to try and embody this dialectical stance that we call empathic confrontation, where we say, I get what you're doing, or at least I'm really curious about what you're doing. That's the empathic part. But it's not working. Or I think it's really not in your best service, or I think it's harming the relationship we have here. So empathic confrontation is a dialectical approach. A third stance, which is completely different than the first two, is what we do when we see the introjected, sometimes they're called parent modes, I don't like that term, but these voices that are harmful toxic, hurtful towards the patient themselves, the way we want to respond to them is certainly not through limited reparenting, because they're not kids. They're sort of introjection of somebody harmful, or at least uncaring enough towards the child. So I want to parent that part, and I'm not particularly empathic toward it. Instead, I want to do some sort of challenge to it. Now, there's arguments about how that challenge should be and whether it should be a complete all-out war. That's the way that Jeff Young originally thought about it. I think over the years, people have realized that that often not only doesn't work, but in fact is harmful. And so we tend to, these days, think of it more as sort of doing almost like parent training with the introjected parent inside the patient's mind, where it's like, you're not doing your child a service. But there could be some cases where it would be an all-out war. I'll give you an example with a patient of mine whose parents divorced when he was very young, and he moved in with the mother and the new husband, who then had a younger sister, a baby. And he described how for years his feeling in that house was a feeling that he wasn't wanted and that he didn't belong, that he wasn't allowed to open the fridge, for example. He wasn't allowed to go into the kitchen and get any food from the age of 6 until he left home at 18. The work we did that at some point, one of the sessions involved using chair work, a technique that is something we like using a lot and we learn a lot from Les Greenberg and others and how to do it. And in that empty chair technique, we put the father in the empty chair, told him everything we think about him, and at some point grabbed the chair and threw it outside of the room in a very dramatic way to get the point across of like, this is not an acceptable voice. This is not a part that we like. So in a way that was an extreme kind of dealing with this introjected mode that doesn't tend to be the way I work, but it sort of illustrates it. Finally, when we see the patient having a healthy adult mode, or even the inkling of a healthy adult mode in the room, we ask ourselves, do we need to do schema therapy? That may be the moment where I can go and do short-term dynamic therapy, or I can do CBT, or I can do all sorts of other things that are quite useful. But if I'm still in a schema therapy framework, I think about that moment as a moment in which I've got a partner. I've got somebody that I can join and I can collaborate with. And that's a very different stance than limited reparenting or empathic confrontation or elimination or fighting or educating these modes. It's a form of modeling, joining, collaborating, and that's where collaborative empiricism, which I think is a beautiful, beautiful, beautiful stance in CBT, can come in if I've got a partner to work with. Which brings me to the last theme that I wanted to say, that all this, we talk about the techniques and practices in schema therapy, but what's important for me to get across is that this is an approach that has moved quite far from where it started. In fact, the name, which connotes a kind of cognitive idea, because schema is a cognitive, is sort of a misnomer. And the work itself is not really cerebral, and it's a lot more experiential. It's really influenced quite strongly by ideas from Gestalt therapy and emotion-focused therapy, like chair work, ideas like imagery work, which have been developed quite strongly in schema therapy. And I'd say towards the second half of the therapy, once there's readiness for change and we know what the changes are, a lot of behavioral techniques as well. And I think the least important of the toolboxes that we have as schema therapists are actually the cognitive ones, sort of a non-cognitive cognitive therapy. All this is embedded within a relationship, and I think that one dimension that I was thinking of as people were talking about their work, that I think distinguishes schema therapy from other approaches within the cognitive behavioral tradition is that it tends to involve using the therapy relationship in a different way than most cognitive therapy. I think the relationship is really important in cognitive therapy in general, but I think it's often used as a vehicle for getting the work done. And I think in schema therapy, some of it is the corrective emotional experience or corrective relational experience that is central. Which brings me back to a conversation we had yesterday about whether I think this is Stephen. This is a response to something you'd mentioned regarding, I think, ego psychologists and how it was sort of off-putting for you for a while that they were so looking at rationality and adaptation. And I think we don't think that looking at irrationality and emphasizing adaptation are contradictory. We think you could do the same thing, or you should do both of them at the same time. So now we're getting to the pop quiz. So what sort of integration is this? I always thought this was a theoretical integration. So it tries to create a new theory that integrates these different ideas. But yesterday, when Golan spoke, I decided I'm going to embrace this idea of accommodative integration. If I understand correctly, the difference is there just a theory that I then now claim is the right theory, or is this idea of are we constantly adapting and changing? Okay. But the good version. Okay.
Thrownness. They start somewhere. They were trained somewhere. Jeffrey Young wasn't trained at the Tavistock, so his nomenclature is very Beckian cognitive, even though ultimately he develops a theory that is highly compatible with object relations theory. His starting point is as such that he developed his cognitive theory to the point where it has been transformed. I don't think that...
Right, so,
yeah.
So theoretical integration is accommodative integration, and we all passed the quiz.
Almost.
Almost.
Shahar 2021.
And if there's an emphasis that I want to highlight, it's that there's a formulation that's based on needs and on parts, which are things that many of you mentioned over the last couple of days, including Rumi. So, Rumi was the first one to talk about it. It talks about a flexibility in stances. I think you called it orientation. I wrote it down here. You called it technique versus orientation. So I think it's the orientation that we have or stance that we have. But our argument is that we should have multiple stances, not one. We should be flexibly responding to the patient's modes. And then beyond that, it's technical creativity and eclecticism with emphasis on experience as much as possible. And all this is to say that if this is appealing to you, I'm going to pass out the sign-up sheet for you to become card-carrying schema therapist. I don't think you need to be card-carrying schema therapist. The last line of the slide, the do more of it, is a quote from every time I've seen Peter Fonagy speak. Every time. It's happened, I think, 4 times by now. There's always a part in his workshops or talks where somebody in the audience says, wait, so how is this different than what we do in name a therapy? And then somebody else says, and we do this too in ACT, and we do this in DBT, and we do this in self-psychology. And his answer every time in each one of those talks was, great, do more of it, which I think is a great answer. So in a way, if mentalization, which is what he's selling, is something we should all do more of, I think that these things... Yeah, but except I don't think there needs to be a barrier. I think we need to be working towards having as much of a universal language for thinking about what it is that we do. I'm proposing nice terms that I think, I'll give you at a discount. The terms of needs and modes or parts of the self, but I think they sound familiar to what you all are doing it, and if you're doing it, great, do more of it. I think what schema therapy has been able to do quite well is serve as the good cop, back to our department, serve as the good cop where people start seeing that it's not either or. They can learn how to do really good work with anxiety while also seeing the person as a whole. There's an experience that even I, for years now, have been teaching a second-year practicum. So in the first year, they come in and do psychodynamic psychotherapy, and then they come in to the second year and right, well, yes. They come into the second year, and at least what I tell my practicum students, who by that point have had a year of psychodynamic training, is I want you to keep doing everything you've been doing until now. Except I want you to please not sit on your hands anymore. Like, just let your hands out. Or have a pad of paper and write some things in the session. And it's a symbolic thing, this pad of paper, but it's the idea of your sensibility, your attentiveness, your being able to I don't know the English expression of קשב מרחף על כל חלקי החוויה, free-floating attention, so which I think is a beautiful concept. I want them to keep doing that while at the same time looking for needs, looking for modes, and trying to communicate them to their patients relatively quickly, because they've got 30 sessions, it's a year.
Behavioral activation exposure is part of that?
Anything can be a part of it, technically. Anything can be a part of it. And behavioral activation in particular is a wonderful technique for changing schemas, right? Or exposure. It's a wonderful way for doing experiments. So in a way, the logic of cognitive therapy is here too, where we want them to go out into the world and change the way they see themselves and the world. And the best way to do that is to get experiences, but we want to do it in a way that they understand it as embedded within a view of their entire personality. And I'll say, in the spirit of humility, or maybe I'll keep that for tomorrow, but I'll say that I don't think schema therapy is necessary at all times. I think it's perfectly fine to do much briefer interventions that don't require all this, heavy lifting, but sometimes it's necessary. And I think when it's necessary, it gives us a universal language for doing it that has been called by some people as kind of psychodynamic. And Golan sometimes claims that actually this is psychodynamic psychotherapy. What? That actually schema therapy is psychodynamic. So maybe it's hard to categorize, but it's hard to categorize because I think it tries to strive for this universal.
Do you want to